Low-grade inflammatory activity can persist in your body without you knowing. No fever, no swollen gland, no obvious injury, no clear sign that anything is wrong. And yet, a low level of immune activity can persist for months or years, quietly influencing the lining of your blood vessels, the stiffness of your arteries, the risk that atherosclerotic plaque will continue to develop, and the biological environment in which your blood pressure is being regulated. This is chronic low-grade inflammation. Not the kind you feel in your ankle after a twist. Not the kind your doctor treats with antibiotics. A quieter, more diffuse, body-wide state of low-level immune activity that does not announce itself, but the cardiovascular research has increasingly connected to hypertension, atherosclerosis, heart disease, and metabolic dysfunction. This chapter examines what it is, how it interacts with the systems this series has already described, and what it means for the man trying to understand the full picture behind his pressure. Begin with what acute inflammation is designed to do. Because to understand the chronic version, you first need to see the healthy version operating correctly. When tissue is damaged, when a pathogen enters, when an injury occurs, the immune system responds. Immune cells are recruited to the site. Signaling molecules, called cytokines, coordinate the response. Blood flow to the area increases. The tissue begins to repair. When the threat is resolved, the inflammatory response is regulated back down. The cytokines reduce. The immune activation recedes. The body returns toward its resting state. Acute inflammation is protective, activated when needed, then actively regulated toward resolution as the threat is controlled and repair progresses. The problem addressed in this chapter is what can happen when inflammatory activity persists, when the transition toward resolution remains incomplete. Here is where inflammation enters the cardiovascular story. The endothelial cells lining the blood vessels, which you met in Chapter 8, are sensitive to the inflammatory state of the body. In a pro-inflammatory environment, endothelial cells can express adhesion molecules on their surface. These molecules attract circulating immune cells, which can bind to the vessel wall and contribute to local inflammation. Nitric oxide availability, which supports healthy vascular tone and blood pressure regulation, can be reduced. Endothelial function is impaired, and the vessel wall becomes more vulnerable to the atherosclerotic processes described in Chapter 8. This is one of the pathways through which chronic inflammation intersects with blood pressure regulation and cardiovascular risk. Not the only pathway, but a documented one. Inflammation and hypertension are not simply associated. They share mechanisms. Inflammatory signaling can influence vascular tone, renal handling of sodium, autonomic nervous system function, and the vascular remodeling that contributes to sustained elevated pressure. Hypertension itself can promote vascular inflammation, and that inflammation can feed back into the mechanisms driving hypertension. Another network, another set of systems capable of reinforcing one another. Some specific inflammatory molecules are worth naming because they appear repeatedly in cardiovascular research and because understanding what they do clarifies the picture. Interleukin-6 is a cytokine produced by immune cells, fat cells, and other tissues. It stimulates the liver to produce C-reactive protein, one of the most widely used clinical markers of systemic inflammation. Its role in the body is complex and context-dependent, not simply harmful, but when chronically elevated in the absence of acute infection, it is associated with increased cardiovascular risk. Tumor necrosis factor alpha, another cytokine, participates in the regulation of inflammation, cell survival, and immune function. In chronic inflammatory states, it can contribute to endothelial dysfunction and impaired vascular regulation. C-reactive protein, produced by the liver in response to interleukin-6, is elevated in states of acute infection or injury, but also in lower-grade chronic inflammatory states associated with cardiovascular risk. High-sensitivity CRP, the version of the test designed to detect these lower-grade elevations, is used clinically as part of cardiovascular risk assessment. These molecules do not all play the same role. Cytokines such as IL-6 and TNF-alpha can participate directly in inflammatory signaling. C-reactive protein is especially valuable as a marker, evidence that inflammatory activity may be present and relevant to cardiovascular risk. A marker is not automatically the cause of the disease it predicts, but it can still reveal something important about the biological environment. Now, the connections this series has been building are relevant here. Chronic psychological stress has been associated with altered immune regulation and elevated inflammatory markers in some populations. The mechanisms are complex and differ between individuals. Chronic stress activates the HPA axis. Cortisol, in the short term, has anti-inflammatory effects, but the relationship between chronic stress, HPA axis regulation, and inflammation is complex. In some settings, particularly in chronic stress with altered HPA regulation, reduced sensitivity to glucocorticoid signaling in immune cells has been observed. This is sometimes called glucocorticoid resistance, and it can be associated with poorer regulation of inflammatory activity. Chronic stress may also promote low-grade inflammation through other pathways, including sympathetic activation, sleep disruption, and behavior changes that affect diet, physical activity, and body composition. The relationships are not linear. They interact. But the general picture, supported across a large body of epidemiological and biological research, is that sustained psychological stress can promote a pro-inflammatory state, and that pro-inflammatory state can interact with blood pressure regulation and cardiovascular risk. Visceral fat deserves specific mention here. Fat tissue, particularly visceral fat around the abdominal organs, is not simply an energy store. It is biologically active tissue. Visceral fat cells release cytokines and other signaling molecules that can promote inflammation. Visceral fat is associated with insulin resistance, metabolic syndrome, and cardiovascular risk. And the relationship between chronic stress, cortisol dysregulation, and visceral fat accumulation is documented, though mediated through multiple interacting pathways, including appetite, activity, sleep, and metabolic function. Chronic stress and altered HPA axis regulation have been studied in relation to appetite, sleep, metabolic function, and abdominal fat distribution. But visceral fat accumulation is multifactorial. Energy balance matters, genetics matter, sleep matters, physical activity matters, insulin sensitivity matters, and the distribution of adipose tissue itself matters. But once visceral adipose tissue becomes metabolically dysfunctional, it is no longer just carrying energy. It can participate in the signaling environment shaping vascular and metabolic health, and it adds its own pro-inflammatory contribution to the system. The measurement is important. Chronic low-grade inflammation is not invisible to medicine. High-sensitivity CRP can be measured through a standard blood test. It is used in clinical practice as part of cardiovascular risk assessment, alongside traditional risk factors like blood pressure, cholesterol, smoking, diabetes, and age. In selected cardiovascular risk assessments, a clinician may use HSCRP to add information beyond traditional risk factors. It is not required for every patient, and an elevated result does not reveal the source of the inflammation. But where clinically appropriate, it can contribute another useful piece to the risk picture. What changes inflammation? Exercise. One of the most consistent findings in the literature is that regular physical activity reduces inflammatory markers, including CRP. Multiple mechanisms are proposed: direct anti-inflammatory effects, reductions in visceral fat, improvements in metabolic health, autonomic effects. The evidence is strong. Sleep. Sleep disruption is associated with elevated inflammatory markers. Improving sleep may help support healthier inflammatory regulation, especially when chronic sleep loss or sleep disruption is part of the problem. Weight management. Reductions in visceral fat are associated with reductions in inflammatory cytokines. Diet. Dietary patterns high in ultra-processed foods and low in vegetables, fiber, and omega-3 fatty acids are associated with higher inflammatory markers. Mediterranean-style dietary patterns are associated with lower inflammation. Smoking cessation. Smoking is a potent driver of vascular inflammation. Stopping smoking is associated with reductions in vascular inflammatory burden. And stress reduction, to the extent that chronic stress contributes to a pro-inflammatory state, practices that support autonomic regulation, sleep, and psychological well-being may also support a less inflammatory physiological environment, not as a replacement for the established interventions. As part of the same picture, this is the thread Chapter 9 promised. Inflammation is not a separate topic that arrived uninvited. It runs through everything, through the vessels described in Chapter 8, through the cardiac changes described in Chapter 9, through the stress response described in Chapters 2 and 3, through the cortisol system described in Chapter 4. Through the metabolic story, this series will continue to examine. The fire is not in one location. It is in the conditions. Change the conditions, and the conditions that sustain the fire begin to change with them. Not through one practice, through changes across the system. Chapter 11, Why Men, examines how hypertension and cardiovascular risk can appear differently across male and female biology. The influence of age, hormonal signaling, body composition, behavior, sleep apnea, healthcare patterns, and the risk factors that become especially relevant in the male body. This is the silent current. Chapter 10. Complete. Your body has been trying to tell you something. It is time to listen.